All right, so next up is Govindarajan Narayanan from the Miami Cancer Institute in South Florida. He has seen so many EEG patients and performed IRE and is known fondly by many of us as Dr. Raj. So we are excited to hear more from him about IRE and the management of EHE in the liver. And please warmly welcome Dr. Raj.
Thank you. Can you all hear me? Can you hear me? Okay, next slide, please. First, would like to thank the organizers for this opportunity to speak to all of you. I honestly wish I had more time today. It's a Friday, and I also happen to be on call today, so I managed to carve out an hour for this. But thank you very much for this. And so my talk today involves the potential role of local regional therapy in the management of EHE, or specifically hepatic epithelioid hemangioendothelioma. So this disease, as initially described in 1982, can involve the liver, lung, skin, soft tissue, and bones, a greater female to male incidence, with a peak incidence around 30 to 40 years. It's considered a low-grade tumor, which tends to be multifocal, and 30% could be metastatic at presentation, with the lungs being the most common site. And the liver, it's usually defined as a low to intermediate grade malignancy. Next slide, please. So in the liver, the angiographic examination of this particular disease is shown. Typically, there are multiple avascular lesions which tend to enhance more on the venous phase of the injection. And these lesions are surrounded by stretched vessels, which is due to a veno-occlusive process, which could be common. Patients can have portal hypertension, splenomegaly, ascites, tissue ischemia, and the tumors tend to grow, some of them slowly. And usually what we've seen is once they've reached a size limit of a little over 3 centimeters, the progression seems to be faster, at least in the small number of patients that I've seen. There seems to be stromal inflammation observed in the majority of the cases, and 99% of these lesions involve veins versus arteries, as the disease prefers low-pressure vessels. Next slide, please. So the tumor tends to follow pre-existing vessels along the sinusoids and through the hepatic veins, and the tumor cells are observed in sinusoids at a distance from the tumor foci, and intravenous growth in the form of polypoid tufts is noted in the majority of cases. Next slide, please. Just to go a little bit into the imaging, there was a comment about imaging. Usually MR seems to work pretty well in identifying these lesions, especially with contrast enhancement. On the T1, you see them as low density, and you can see the high signal intensity with peripheral hypointensity seen on T2 weighted imaging. Next slide, please. And so as we talked about the multifocal growth, with the perivascular involvement, these nodules tend to coalesce and form confluent tumor masses, something I've seen even in the patient that we've treated, where the lesions which are in close proximity to each other sometimes tend to coalesce and end up becoming or looking like a single lesion. Next slide, please. So here's some of the heterogeneity of these tumor when you look at them on MR. Again, these lesions can coalesce, and so there's a certain level of stenosis of the feeding vessels. The two images that you see here, the first box, which is marked as A, you see a T2 weighted MR image, which shows a heterogeneous high signal intensity. The tumor is marked with the arrows there. And in B, which are 3D gradient echo fat saturated. These are contrast enhanced, to put it simply. It shows a peripheral rim-like enhancement in the arterial phase, which is on the left. And you see a gradual filling in the portal phase that's in the middle, and a low signal intensity on the right. So that's a typical appearance of this tumor on contrast enhanced MRI. Next slide, please. So this is just to show you a pathologic specimen of the tumor next to the portal vein and the IVC. Next slide, please. So coming to the main crux of my conversation today is involving the role of local regional therapy. And till about 2010, this technology was not commercially available, which is irreversible electroporation. And this first paper, A Human Experience of Using IRE, was published by Professor Ken Thompson from Australia. And I owe my exposure and experience in IRE to him. He was the one who introduced me to the technology and shared his expertise. And since then, for the last 11 years now, I've continued to use this technology in different disease processes. But as far as EHE goes, next slide, please. He was the one who used it in the first human experience and included that as part of his publication back in 2011 in the Journal of Vascular and Interventional Radiology. So we're going to talk a little bit more in detail about this technology, but one of the key factors is this is not a thermal ablative technique. The traditional ones that we used before IRE, such as microwave ablation, radiofrequency ablation, or cryo, are classified under the category of thermal ablation. And in 2009-10, IRE was introduced first as a non-thermal ablative technique. And here in this example, it shows that the segment 8 lesion was not treated, but the other lesion, which involves segment 5, was treated. But after the ablation, you can see that the portal vein branches, which run through the tumor, are still patent. And a month later, when you look at the follow-up, you can see the dramatic decrease in the size of the treatment zone. Next slide, please. So again, we're going to touch on all this in a little bit more detail. And as far as use of this local regional therapy in EHE, the data or the literature is very scarce. And other than Dr. Thompson's mention of this and this case report, which was published in the Journal of Clinical Oncology, this was a single patient, next slide please, who had Bartonella infection and also EHE. And this patient was treated with IRE, and biopsies and imaging showed that there was destruction. Next slide, please. So my exposure to this IRE, again, like I said, started back in 2010. And we used this as a tool to treat complex locations of tumors, initially predominantly in the liver, tumors that were close to blood vessels and critical structures like as bile ducts, where because of the non-thermal properties, this was considered to be safer. So what exactly is electroporation? This technology has been around for a few decades. And when you expose a cell to electricity, short pulses of high voltage, low energy DC current, it opens multiple pores in the cell membrane and thereby disrupting the homeostasis mechanism. Next slide, please. The technology has been used up to about 1,000 volts, which was called reversible electroporation, and was used to insert proteins or small molecules and also genetic material into exposing it to this low level of electricity, and also for electrochemotherapy in the management of diseases such as melanoma. So the scientists at UC Berkeley worked with this technology, and they found that when they increased the voltage up to 3,000 volts, they saw cell death independent of the chemotherapy, and termed this as irreversible electroporation, and that's how the technology was born. And this was commercialized, like I said, back in 2009-10, as and was called the nano knife. There's no knife involved here, but of course they gave this term nano knife. And so we use this. It can be used both in the surgical environment as an open procedure or laparoscopically by a surgeon, or can be done percutaneously with image guidance, which is what I do. Next slide, please. So to summarize, it's a focal non-thermal ablative technique that uses high voltage, low energy DC current. So when these pores are open in the cell membrane and they do not close, the external milieu of the cell floods the internal part and the cell organelles die. And the mechanism is considered to be healing involves apoptosis or programmed cell death. But there's been a little bit more research done in that area, and I'll talk about this towards the end of the talk. Next slide, please. So this is the third generation of the device. This is called the version 3, which you see on the left. It's got a slightly bigger footprint than most of the ablation generators that you see. It has a touch screen where you can adjust the parameters. And on the top of on the right, where you see are the two probes. You need a minimum of two, a positive and a negative, to create a treatment zone. But you can go up to a maximum of 6, depending on the type or the size of the tumor. Sorry. And below that, you see what's called as the AccuSync device. So early on during Dr. Thompson's experience, they noticed that some of these patients, when they delivered 3,000 volts of electricity, had cardiac arrhythmias. So they introduced this AccuSync device. Next slide, please. So now this device is part of the IRE setup, and this is gated to the patient's EKG. It's an independent device. Next slide, please. And what this AccuSync device does is it detects the rising slope of the R wave in the cardiac cycle, and it sends a signal to the nanoknife machine. And there is a pause of 0.05 seconds before the electrical energy is released during the refractory period of the cardiac cycle, and thereby significantly reducing the risk of cardiac arrhythmias. So that is now, once again, part of the standard treatment. Next slide, please. So why is this technology different? And we talked about this being predominantly non-thermal. So therefore, it spares the collagenous skeleton of the blood vessels. So animal studies have shown that there is damage to the intima, media, and adventitia of the blood vessels, but these cells quickly repopulate. And but since the inner collagenous skeleton is preserved, we're able to see preservation of the blood flow. You saw that on the initial image of Dr. Thompson's case, and I'm going to show you some more cases. Next slide, please. So this procedure has to be done under general anesthesia. You cannot do this with conscious sedation like the other other ablative technologies. You can do cryo and microwave sometimes with just Versed and fentanyl, but you require complete muscle relaxation and general anesthesia for using IRE. Next slide, please. And patient positioning is important. This is a video. If you click at the bottom, you're going to see it. So you don't want to extend the patient's hands above their head. Can we click on, yes, please. Sorry, I'm sorry, I don't know why it flipped, but so this is kind of a low-tech method that we use where we use a bunch of towels and strap the patient's arms on top of it across their chest, and thereby we prevent the extension of the arms above the head and avoid brachial plexus injuries. Next slide, please. And this is another quick video which shows the actual placement of the needles. These are pretty sharp 19 gauge needles. They're also pretty flexible. And using the black lever that you see on the needle, you expose the active tip of the needle. It's a diamond tip, so it's pretty sharp. And then you advance it little by little using imaging guidance to see where you want to take it. Next slide, please. Now, once your needles are all in place, in this particular case, we're using 5 needles. We do what's called a 3D reconstruction, and we make sure that the needles are separated no more than 2.2 to 2.3 centimeters. Anything more than that is going to cause high current errors, and we use a 3D software to make that measurement. Next slide, please. And once this is also a short video. Once the needles are in place and the distance has been confirmed, we turn on the generator. And what you're going to see is the movement of these needles, which is very different compared to a microwave or cryoablation. And so that's, if you've not seen that for physicians to see it for the first time, it can be a little alarming. So usually, once you have the needle placed in the liver, there's not much motion, but we're always watching it just to make sure that the probes don't move. Next slide, please. So some of the case examples that I wanted to show you. Next slide, please. That's a picture of our center, the Miami Cardiac and Vascular Institute. So this is a case where you can see the enhancement. Again, when you go to the right, you're going to see that the venous phase, the portal vein is enhanced, and you can see the heterogeneous enhancement of the lesion. Next slide, please. And the same patient after the treatment, you can see the big zone that looks dark, and the bright linear structure that runs through it is the vessel, which is preserved without any damage. Next slide, please. Here's another example of a patient with some long-term follow-up. A patient had microwave ablation of another lesion. Again, I'll touch up on microwave ablation towards the end. This particular lesion was seen at the crux of the veins. One of the disadvantages or limitations of thermal techniques such as RFA and microwave is when you have the tumor right next to a major blood vessel, you also have the factor called as a heat sink, where the flowing blood in the vessels steals some of the heat, and thereby the part of the tumor close to the vessel is not completely ablated. With EHE, you also have the problem of the tumor being propagated along the veins. So here, in this particular case, we chose to use IRE. Next slide. And the left is a video. You can see what we try to do there is bracket the tumor with 3 needles, 1 along the superior aspect of it and 2 along the inferior aspect of it. And on your right, you see the 3D reconstruction. This is a freehand needle placement with CT guidance. And that's the triangular shape that we got to bracket the tumor. And you can see the separation of the needles that's marked. And we completed the treatment after that. Next slide, please. So at any given time, the treatment of you need 70 pulses to be delivered between 2 needles to complete a treatment. So when you're using 3 needles, even though you have 3 needles, it goes from one pair to another. So therefore, you can use even number of probes or odd number of probes. It does not matter. So here's another example of the immediate zone. What I wanted to highlight on this is the size of this ablation zone after we were finished. And we're going to look at some of the follow-ups of the same patient. So this was the immediate scan. Next slide, please. And this is a video of the post-IRE where you can see the vessels being preserved and the ablation zone. Next slide, please. And so this is about a month after the treatment. There was a significant drop in the size. I'm not sure if you're able to see in this slide, but it was nearly at least 2 to 2.5 cm less than what we had seen after the immediate ablation. Next slide, please. And same patient, this is just a shot to show you the decrease in size with the measurements. Next slide. And this was about 8 months later, where we can see that we had another 5 millimeter decrease in size, but you also see preservation of the vasculature right next to the tumor. Next slide, please. Next slide, please. Same patient. You can go to the next one. So this is another one just to show you a multifocal tumor where this patient had multiple lesions, but we targeted the largest ones, and we treated about 3 tumors at the same time in a single sitting. Next slide, please. The first one is a video which shows several lesions. We picked 3 particular lesions which are highlighted on the right 2 images. One is close to the ribs. Next slide, please. So next one. Those were the 3 that were targeted for the treatment. Next slide. So here are the needle placements and the 3D reconstructions. We used 4 needles for 2 of those and 3 in 1. Next slide, please. And so this was the immediate post-procedure. Again, you kind of can, if you squish it, you can see the tumor and the margin or the dots, black dots. That's where the needles were placed in respect to the tumor. Next slide, please. So this is the immediate post. Next slide, please. This is a 1-month follow-up. There's another follow-up on this patient, which I could not include in this, but we thought we'd gotten a good result, and that was also seen on the MR with the diffusion-weighted images and the enhancement characteristics. Next slide, please. So very quickly, I'm just going to run through microwave because some patients have been interested in this technology and have been recommended to go through with this technology. We use a lot of microwave, cryo, and IRE in our practice, but I feel that, again, with the limited, we've not done a huge number, but for the EHE world, I think that's about 20 patients with significantly more number of lesions. If the tumor is away from a critical structure, not near a major vessel, I think microwave might be able to overpower the effect of the growth along the venules and give you an ablation zone, because here you're using electromagnetic waves and you're creating frictional heat and cell death happens by coagulation necrosis. Next slide, please. Microwave, it does not, the impedance of the tissue does not seem to affect microwave as opposed to radio frequency ablation. So you can put it in locations which have high impedance and burn it. I call it RFA on steroids because you can get much bigger zones much faster. Next slide, please. But here, next slide, please. I'm going a little faster because of the time. This is a particular patient, not an EHE patient, but had breast cancer metastases to the liver, which was treated with microwave. This was in March of 2019. Next slide. The reason I'm showing this slide is the way the healing happens. And if you look back after several months or even close to a year, the treatment zone looks pretty much the same because the area has undergone fibrosis and scarring. While you can see some change in the size with thermal ablation, it's not a significant change. Next slide, please. So this was studied, the response to IRE was studied by Professor Sugimoto in Japan, where they had 21 patients in the liver where they used both IRE and radiofrequency ablation. 10 of them had IRE and 11 of them had RFA. And they looked at what was the immune response after these ablations by studying this. And one of the things that they found, which was really interesting, was the fact that patients had a significant increase in the macrophage migration inhibition factor immediately after IRE, and they did not see that with radiofrequency ablation, and they postulated that this increase could facilitate in the early repair process and the shrinkage of the tumors post-ablation with IRE, and that's something we consistently see in the liver using this technology. So next slide, please. So to summarize, what we've seen with our, I think I would definitely call this a limited experience because we're still in the very early stages. I've used this technology in this case, in this tumor over the last 7 years. I'm pretty selective about the patients that we use. I always try to consult with our medical oncology colleagues and Dr. Bulke to get their opinion about whether we should offer this treatment or not. And what I can safely say as a conclusion is in the patients that are right candidates where we've used it, it works. It seems to kill the tumor that was exposed to IRE, and with the healing process, we do see the size decrease and the healing. One of the advantages is we're able to go near blood vessels because it's not thermal, and we are not. It does not seem to impact bile ducts the way a thermal ablation would do. But having said that, I think there's a lot more questions for which we need answers because we use ablations in a significant amount in patients with primary liver cancer and also in colorectal metastases. But those have been studied. The numbers are huge. Studies have been done, both retrospective and even prospective and randomized trials where we've shown that there is a value for ablation. And then there are categories of patients where we try to downstage patients who are initially not transplant candidates with local regional treatments. So at this point in time, given the limited experience, all that I can say is that it seems to work. But where this technology would fall in the algorithm of this disease process and the treatment needs to be further studied. Could this be used to bridge patients to transplant if they have a longer wait time? Is that necessary in this particular disease process? Maybe it's not like a hepatocellular carcinoma, as we heard in the previous talk. Or could this be used in combination with the systemic treatment that are being used by medical oncologists? And one of the areas of interest with IRE is the immune response that happens after this ablative technique that is being studied, has been published now in at least 3 animal studies, and there seems to be a lot of excitement there compared to other thermal imaging modalities. IRE seems to have a immune response that seems to help in a mouse model, for example, in pancreatic cancer, to overcome the effect of the stromal tissue to get the chemotherapy into that cell. So is there a benefit of that? Again, we need more studies and research to come to those conclusions. But as of now, procedure seems to be fairly well tolerated by the patients. And so far, other than some minor complications, we've not had any significant complications in the group that we have treated. So I would stop here and happy to answer any questions. Thank you very much for the opportunity.
All right, we've got a handful of questions from the audience here. So first question, what are some of the challenges or barriers that patients may experience in getting IRE or evaluation for this treatment?
I think one of the limitations is the number of centers that offer this treatment and the experience of the people offering the treatment. Even though IRE has been around for 10 years, it's still mostly predominantly a surgical tool used a lot by surgeons more than interventional radiologists. Although I think over the last 2 to 3 years, I've seen that trend change. There are multiple sites now that are offering percutaneous treatment. So I think finding sites with experience with the technology is probably the first challenge. And the second challenge, I think, for EHE patients is like with any other technique, anytime, since there's no standard of care for this, the insurance companies keep giving them the runaround and saying that this is experimental and the data has not yet been published and therefore we cannot approve this. So I think most of our patients have gone through significant difficulties getting this, and there's a lot of pressure on our team and the peer-to-peer appeals. And since we've been able to show results in these patients, it's getting a little better, but we're hoping to have this series published pretty soon. We're still waiting on our IRB approval, but once we get that published, I hope to have a better success with the insurance companies.
Excellent. Well, looking forward to that. Question here about resection. For resection where there's reoccurrence, are you seeing IRE used to treat the reoccurrence that may be along the resection line?
So we see that a lot more in patients with colorectal cancer who have had resection, and resection recurrence happens along the margin. I have not treated an EHE patient who's had recurrence along the resection margin. But if there is a patient, we can use it.
Okay. What is the immediate and the chronic morbidity of the procedure?
So immediate, what we've seen in patients with solitary lesions is pretty well tolerated. There have been a few handful of patients that have done more than one lesion at the same time. And at this point in time, I still don't have the answer. A couple of them had numbness and weakness along their lower extremity. We worked them up for pretty much everything. Everything was negative, including vascular and nerve. The only thing we could come up was the position in the CAT scan table, which is not the most comfortable table, and lying on the table for a few hours. So after talking to my colleagues at Mayo Rochester in the IR department, Dr. Matt Karlstrom, one of the things that they use is a bean bag or something that hugs the patient and provides more support. And we've gotten that now in our institution, and I'm hoping that that should not be a problem. So that's one of the things I've noticed in a couple of patients. But other than that, most of them have dull pain in the area, and the average has been on a pain scale of 0 to 10. They're between 4 to 5, and vast majority of them have gone home the next day. Some of them have stayed a little longer.
Have you seen any decrease in the size of extrahepatic lesions in patients that have undergone the IRE procedure?
No, we've not studied that as yet. And no, I've not seen patients where there's been a decrease in.
What tissues outside of the liver is IRE used for or has been contemplated to be used for?
So I use it exclusively in the pancreas. That's one of my areas of significant interest. We've published quite a bit on that. Pancreatic cancer is one area. It works well in central renal tumors where you have blood vessels and critical structures, where other ablative techniques could cause complications. In the liver, we use it anytime if a tumor is next to any significant vessels, arteries and veins, where we think the patient is an ablation candidate, or next to a bile duct, gallbladder. And I've also used it in a number of patients who have solitary metastases that are close to the aorta or colon or other critical structures where we cannot use other ablative tools.
When a clinician is choosing with the patient among the various options, Is there any restrictions on use of this procedure based on the size of the tumor? So for example, if the tumor is a large tumor, are some of the thermal approaches the only viable ones, or will this also work for very large lesions?
So again, even though I use thermal a lot, I have not used it in EHE, although I've heard about anecdotal experiences of patients having gone through a microwave ablation. So I do not know the long-term follow-up on those and how those tumors responded. Uh, the I think the size that I'm comfortable with saying that I will be able to get the tumor in a single treatment is between 3 to 3.5. You can go up to a 6 needle and treat a bigger zone. Anytime your ablation zone is bigger, you also have a post-ablation syndrome where patients could have pain, fever, and all those symptoms that go with it. But when I have tumors which are larger, we always try to talk to patients about the possibility of more than one treatment. Thereby, if this is the treatment modality for them, then I talk to them about the possibility of more than one treatment.
Got it. And maybe related to that, and we have time just for this last question here, what is the maximum number of lesions you've treated in a single patient using this approach?
About eight tumors in one patient.
And that was in one procedure?
No. In a few sittings.
Okay. Well, we're out of time for Q&A. Thank you so much for this very, very informative talk, and look forward to seeing publications on this to help with the payers.
Thank you.
All right. Well, thank you so much, Dr. Raj, not only for being here today, but for being such an advocate for EHE patients. I know that your team spends so much time reviewing scans and providing feedback if IRE is a valid option for many of us patients. So we truly appreciate you and your experience with providing another treatment option for all of us. So thank you very much.